must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show. Hey everybody, and welcome to another episode of the Healthcare Education Transformation Podcast. I'm Brandon Powen, and of course I'm joined by my fellow co-hosts F. Scott Fiel and Stephanie Wyrock, and today we have the esteemed pleasure of welcoming Dr. Adriaan Louw, who is the CEO and co-founder of the International Spine and Pain Institute, or ISPI for short, onto the show today. And I must first and foremost say what an absolute honor it is to be speaking with him today, as I really must say thank you for all of your work with pain science, as well with your teaching people about pain class on MedRes that honestly first opened the door to learning more about pain for me, as I really didn't learn any of that in PT schools. And it's been so game-changing in the clinic. So again, thank you for everything and for joining us today.
Oh, you're welcome. I'm glad to join your team and look forward to chatting with you guys.
Oh, likewise. And and Adriaan, for our listeners who perhaps don't know about you, do you think you could tell our listeners your journey and how you first got into studying pain to kind of where you are now with all the great work you're doing?
Yeah, it's pretty easy though. I think the easy answer is I failed. I was trained in a heavy orthopedic model, Maitland based, and as common, the better you get at something, the more people want to see you. And so, because I was heavy manual therapy trained, more people came to see me with more complex things. I mean, it happens to everybody. It happens to the top of the top of the top, right? You want to go see the guy, the girl. Not that I was ever the guy. I'll be honestly say that, but people started showing up with, let's call it weird things, and it didn't make no sense. My pain is spreading, and my pain is worse on a Monday when it's cold, and my football team lost. It made no sense to me. I didn't know if that was a problem with a facet joint or a disc or a muscle, or it just made no sense. And about 5 years into my practice, I mean, I was completely, sorry for the words, but I was burned out. I was completely done. I couldn't do this anymore. And then ultimately what happened is I stumbled upon this pain thing, and it made so much sense. The easiest way to say it is I found out that joints had brains, and joints had families, and joints had friends, and those things mattered. And so that's kind of the thing that happened basically. And that took me down the path of, I'm the luckiest guy in the world. I was around the right people at the right time. I got to meet David Butler, who took me under his wing. I worked with David for 18 years, Lorimer for several years. And it was David that actually told me, hey, you need to do your PhD. You're a young guy. There's a lot of questions we have that you need to answer for us. And, you become a clinician, then you become a clinician that want to do research, then you become a clinician doing research. And that's just kind of how it works. But I just want to make it clear, I had a lot of very cool people around me that was very kind to me. The Butlers of the world, the Mosleys, the Joe Nieces, the Mark Joneses. There's been a lot of cool people around me that put me here, including I might as well just say it, a wife that raised kids while I was following my dreams. So there's a lot of people. That's why but that's how I got here. And the journey has been amazing to help people in pain.
Yeah, I think there are so many clinicians and even newer graduates for that matter who are listening to this and really like, yes, I totally agree that, it's not all biomechanics and there's something more. And I know that the top, and of course, going back to the discussion for today is focusing on really how to teach children about pain. And I must first and foremost highly recommend the Pain Reframed podcast episode in which Adriaan talked with Tim Flynn and Jeff Moore about this very topic previously, as we really felt this was such an important topic to cover, is I think we as clinicians tend to work more on addressing, the catastrophization, maladaptive beliefs about pain, with people whose beliefs and values have been shaped by so many things in their life prior, including experiences, family, culture, and the list goes on, which can be really challenging. But I think that one avenue that we overall as a profession, and frankly, all healthcare providers for that matter, we need to do more of is to set the stage early on in kids to get the right message about pain through early. So there's less catastrophizing, maladaptive beliefs, less chronicity of pain, less disability later in life. So, my first question to lead this off is, what does the research say about how we as humans form beliefs about things? And this is not just specifically to pain necessarily, but about anything in general. What does the research say about how we as humans form beliefs about things from when we're young and throughout our early life?
Well, I think you covered it. It's experiences. There's so many things that happen. First of all, Brandon, a big issue in the pain world right now, and I want to just step one step back to the pain world is there's a big question: is pain, is it nature or nurture? And the answer is yes. We do know, unfortunately, there are genetic things that have been set in motion. Neurotransmitter levels, concentrations of neurotransmitters, ion channel expressions, to certain phenotypes when it comes to disc, collagen. There's so many things. So there is a genetic component, but there's also very strong components on the nurture side. We know that there's numerous studies out of the bigger systems out of Norway, Denmark, Sweden that can track this kind of data. So the answer is yes. It's a combination of what you're born with, but also how mom and dad raised you. But it's not just mom and dad, it's society, it's your culture, it's memories, experiences. We have studies to show that kids that play contact sport early in life struggle less with pain later in life. So how that kid gets exposed to that. Needle pricks in ICU, neonatal ICU units predict pain. Very unfortunate, very hot topic right now is circumcision in little boys are strongly correlated to pain later on. There's just so many things that build in this, experiences, nurturing, that's around you. You. Right now, all four of us on this podcast are we're a summary of what's happened to us from the day we were born, or actually probably from the time we were in the womb till now. And it's that combination that puts us where we are today. And there is obviously the classic biopsychosocial, right? There's biological things that's happened to us. If you sprained your ankle 17 times, then yeah, you're going to have some issues with it maybe. There are psychosocial things going on. So kids, they're the product of their parents, they're the product of society, they're a product of their biology, of their beliefs, experiences. It goes on, but that's probably it. And I'm sure some psychologist right now is frowning his or her eyes right now, but it's probably that, yeah.
Yeah, Adriaan, that kind of leads me into my next question. How much of it have you seen that is subconscious versus conscious?
Oh, Scott, the answer is again yes. The holy grail right now for us is to figure out when is something conscious and unconscious and subconscious, and we believe currently pain is a conscious construct of the brain. And so then the question people ask us, what is consciousness? And there are people with pay scales way above me that cannot figure it out. Mosley, and we've had long discussions about when does something become conscious. And so, Scott, the answer is, again, it's a combination probably. I hate always answering it's a combination, but we are so wonderfully made with all these cool things around us, biopsychosocial stuff. There's got to be unconscious, subconscious constructs, but there's also conscious choices. We make choices. We all have that family member, we call him my brother, that makes decisions that's like, how did you make that decision? And you are where you are today because of what you did. But then there's things that happen to us too. And we're having a really cool conversation about, we don't know. That's so I wish I can start the podcast easier and telling you guys we know, but we don't know. It's so cool.
But I think that's also good information for young clinicians just coming out to realize that even the top of the field isn't quite sure yet. And that's okay. We're working toward it. We're trying, we're figuring it out. So you don't have to come out knowing everything right off the bat. It's good for young clinicians to know.
Yeah, absolutely. There's, as we always tell young students in classrooms, you're going to learn. You shouldn't walk out of a PT school and be the master clinician. You should go out and make us proud and learn for that matter. But there is no excuse not to have compassion, empathy, and care. that is the part that I think is important, and that's okay, because I see it. I see young kids every day in classrooms that I look at them and say, "You're going to be an amazing clinician one day. That's cool. Are you going to be the best upslope manual therapist in the world?" Oh no, that'll take time, but there's no excuse for us to not show compassion, empathy, and respect. Patients, there's a beautiful quote, by the way. Louis Gifford is a guy that started this pain revolution, by the way. He trained Butler and Mosley, myself, etc. And recently his wife, he's since passed away, wrote a beautiful editorial for us. And she said, patients came to their clinic, and even though we didn't help everybody felt like they were listened to and treated with respect. And I think that's a great way. So as our young clinicians listen to your podcast, we're still grappling with what's consciousness, but let's at least, listen to the person in front of us. So, yeah.
Yeah, that's some great advice, Adriaan. And, we can have knowledge and facts, right? But of course, hearing facts doesn't always change people's behavior. So kind of my follow-up here is, what do we know from a research standpoint about how successful behavior change in kids goes, and how is it different from behavior change in adults?
Yeah, Scott, again, that's a great question. By the way, I should have prefaced this earlier probably. I'm not a pediatric therapist. I don't have any specialty in pediatrics or behavioral psychology in kids. I'm a pain scientist, actually a manual therapist who became a pain scientist, who just are intrigued in this notion of starting kids early, right? So there's going to be behavioral people looking at this podcast going, this guy has no clue what he's talking about, right? Now, we studied it, we've looked at it. Behavior change is complex. The one thing we do know is very hard. We spend $2.1 trillion telling people smoking causes cancer, and only 1 in 5 people get the message. I mean, we cannot print larger on cigarette packages, smoking causes cancer, and yet people smoke all the time. We know the obesity, we know with all these behavioral stuff. So it's a hard thing, right? We know that. Dr. Bill Fordyce, who's the father of behavioral medicine, is famously quoted in the 70s of saying, education to behavior change is like throwing spaghetti at a brick, right? It's only a piece. And so one of my frustrations is people think teaching people about pain is going to just change the behavior. Yeah, in a very small group. There's the other part. And for us as therapists, it's the physicality. I'm going to teach you how pain works, but then I'm going to put you on the treadmill. I'm going to take you through exercise. I'm going to build you a pacing program. So I'm going to step back to your question. So it's extremely hard in adults. Prochaska's behavior change model of pre-contemplation, contemplation, all those things tells us we have to have the right message at the right time. And so one of the things I think a lot of clinicians are doing, they're trying to put a square peg in a round hole. Patients walk in pre-contemplation. I have no business. I don't want to be here. I'm here because the doctor sent me. I'm only here so my medicine can be filled. That's definitely not the patient that's going to respond to a cognitive intervention. They already don't like you. So let's put that there. If you step back to kids, Scott, I think the easy answer today is I think kids are way easier because they don't have all this baggage with them. You, me, Brandon, Stephanie, we all have baggage. We are the product of our history. I mean, how many times have we talked to a friend at a barbecue with a beer and you listen to the guy's story and like, this guy just needs to get over his breakup of 1967 and his life will be better. Well, a middle school kid doesn't have that. Hopefully not yet. So they have smaller things, but they have other things, mom and dad, abandonment. There's other things that happen to kids. Kids have unique things. And so to change behavior in kids, I think is easier. We have shown it actually in some of our research that we've started doing some of this research with kids. They're very pliable. They're very malleable, if you will. And so I'm more optimistic with kids because I don't think they have all these other psychosocial stuff yet. And middle school moves to high school, moves to college. The layers become more complex.
Speaking of, some research that you've been doing, Adriaan, you've recently been doing a study looking at pain neuroscience education in middle school children. What do you think you can talk a little bit about this study and how the study was done? What were the findings?
Yeah, so to be honest, we actually have several. You guys are just aware of the one we published. We have several. There's actually, on my desk right now sits the results of our randomized clinical trial. I got it Friday afternoon before the weekend. So the story very simply, Stephanie, is we said, the holy grail, we believe, is preemptive. I need your audience to understand we cannot prevent pain. You never should prevent pain. Pain is normal, but you can prevent disability. You can prevent chronicity, as Brandon mentioned in the intro. So we just thought, kids are exposed to so many bad biomedical models. Take a pill. Pfizer is indoctrinating our kids now, Pavlovian, that if you hurt, you take a drug. Kids Tylenol, kids ibuprofen. FDA just cleared hydrocodone for kids 8 and above. So we're teaching a generation that pain equals drug. And so we just decided, what if we taught little kids? Now, I was taught years ago that 6th grade level is about where kids can take on complex concepts, give or take a little bit. Girls faster than boys, which we all know. And so we decided, these pain stories we built, what if we went to a school and just taught kids this and see what they can do? So one of my colleagues, Dr. Jessie Podolak, she went to Wisconsin. We took 147 middle school kids, 5th grade, 6th grade, 7th, and 8th grade, and we went into their classrooms and gave them a 30-minute lecture on the neuroscience of pain. But we did it in metaphors, examples, stories, and graphics. And lo and behold, the kids' knowledge jumped. What's interesting, though, Stephanie, is that the knowledge jumped higher than any healthcare provider from before and after, and it was only a 30-minute lecture. And the second thing that was shocking is the 5th graders outscored everybody. So we then had to sit and say, wait a minute, why do 5th graders do better than 6th, 7th, and 8th? And the theory then came that maybe as you get older, that goes back to Scott's question, maybe they're getting more influenced by society, mom, dad, the football coach, etc. And so we tested it, and it said it worked. Their knowledge jumped up, then their beliefs changed. So that was step one. We did, by the way, another study, which you're not going to publish, just to test a few things where we measured kids' fear of movement with pain science. So we went to a school in Kentucky. We took about, I think it was 98 middle school kids, 8th graders at that point, and we taught them about pain, only pain, and we measured their fear of movement when they have pain. And it was drastically better, meaning I would move even though I hurt, which that's your behavior shift, right? And then finally, what we're busy with right now is a randomized clinical trial. It's a 4-arm study, by the way. 2 of the arms are done, but we took 578 middle school kids, and one group was taught pain neuroscience in 30 minutes. The other group was taught the biomedical sports medicine model, torn, ripped, rupture, bulge, herniate. And by the way, we didn't go find the scariest presentation you can find. We found a school curriculum that talks about sprains, strains, fractures, concussions that they get in classroom. And then we measured the difference, and it was day and night. The knowledge was higher for pain in the pain group, which that makes sense, right? We taught you about pain, but their fear of movement was drastically, our group was less afraid, the other group was increasingly afraid. Their beliefs about pain and what they would do when they get pain was drastically different. And now what we're doing is we're tracking these kids through their school careers for their attendance in school, PE, sports, going to the doctor, and allied healthcare providers like the PT, the chiropractor, the massage therapist, and then also taking medication. So that's kind of where our research is right now. And ultimately building a curriculum we can take to schools that teachers can teach, or maybe we can give into the hands of therapists to go to their schools to go, because I think there's also a marketing thing for us to be able to walk in as the expert. We are the expert. So that's what we're working on.
Wow, that's really interesting. I mean, it sounds like you guys have really covered your bases as far as really getting involved in the community. Are there any limitations in this study that you can talk about?
Well, the one we published obviously has major limitations because it is simple pre-post. There, we have no idea if it changes long term. There was no control group, right? In the second study's limitations we had pertains to, well, it's hard to say because we're actually in the middle of that study, but and we'll have to see where we end up. But you can go with where's your cutoff? Is it 5th grade, 6th grade, 7th grade? The bigger RCT we're doing in 7th grade, and there was reasons for it. Does this transfer to high school kids? Does it transfer to kids with learning disabilities? We translate this into Spanish. We're working on that. There's so many different limitations for stuff. Every study would have limitations.
So kind of going back now, I mean, I'm going to ask kind of one question off the script here, just because I know that probably listening, there are some parents who are listening, or maybe some clinicians that are parents. What would you recommend, or probably the best way as a parent that we should really how can we best teach our kids about the normalcy of pain so that they really can, I mean, if before we start mentioning maybe helping other people's kids, probably would be best if we helped our
I
own
think
first.
the critical thing, Brandon, is for us to not to medicalize pain. I'm lucky. I'm again the luckiest guy in the world. I grew up in a rural farm in Africa where Dad had no time for pain. Suck it up, walk it off. Don't bleed on that new shirt. We got work to do. And it's kind of the old classic thing, right? So I think we as parents, and I meet a lot of young therapists every week and at seminars, conferences that are the next generation. We're all raising families, and I think it's that combination of don't over medicalize it, but be careful, because some of my instructors that are so pain science sometimes underestimate the biology, right? Your son walks in, he just rolled his ankle, and you say, it's all, sensitized nerves and deal with it. No, it could be a fracture, right? So it's a balance, but I think it's the classic things about, investigate, make sure they're okay, caring, safety, and then encourage to move and move on. Staying away from scary words, encourage self-help, movement, get going, those kinds of things. I think that's important, not bubble wrapping our kids. There is a beautiful study, and it's probably leading to where you're going, but they looked at parents and kids having orthopedic surgery, and they showed a mother's catastrophization in the first 72 hours post-op is one of the biggest predictors of that kid having pain 1 year later. And so I think I would probably just take that easy study and say, don't freak out. If you freak out, they freak out. So just, it's kind of one of those kids, one of those things, turn to your kid and say, you're going to be okay, not a problem, walk away, go, holy crap, that's pretty bad. But, it's kind of like Butler has always taught me, keep your placebo cool, and so that's probably the easy answer I'd give this morning. Don't medicalize it, keep your cool, caress, love, give them safety, and then move. Movement is the biggest painkiller in the world, no doubt about it.
I love that. And I think I'm going to go back to initially kind of getting more into the school aspects. I know that's something that we were kind of talking about earlier. And you had mentioned that you guys were kind of working on a curriculum so that clinicians can take that into schools, and it kind of compromising of metaphors, graphics, be about 30 minutes, more or less. So say that let's say a clinician does have the opportunity to get into a school and teach about pain and working on a presentation in the meantime, or if they're maybe awaiting maybe a standardized curriculum, perhaps like yours. What does your curriculum on this look like?
Yeah, so it's not that far different from what we do with adults, but we basically normalize the pain experience. So we take a pain experience and talk about sensitive nerves as an example. We all step in a nail, nerves ramp up and say, hey, go get some help. But when you guys pull the nail out of your foot, the pain isn't gone. It's still there. It lingers for a day or two or three. And that is sensitization. And so by taking something like that and explaining to them, pain is a normal thing. We do something to take care of it, but then it lingers for a little while to protect us, just in case there's a nail tomorrow. So we normalize pain experiences. We make them understand that pain is a normal experience. There's a lot you can do for it. It typically does not indicate major trauma. You have to investigate and make sure everything is good. I think I'm just sitting and going through our program in my mind. We talk about sensitive nerves, sensitization. We talk about our body's nervous system as an alarm system that protects us. If I punch you in the arm, it's going to protect you. Say, hey, Adrian's a jerk, go get some help. If you step in a nail, hey, pull your foot away. So we teach them how these things work, but that pain is actually a normal thing. We also talk to them about the idea that you can have injuries with no pain, which is kind of cool, right? You wake up, you find a bruise in your body, and you have no idea where that came from. But then we also talk about the idea that you can get pain without injury, like headaches, right? So headaches often don't have a physicality to them. Sometimes they do, no doubt. But there are kids that are lonely, kids that have gone through bad things in their life that can get pain from it. So we make them understand it's normal, it's okay, we understand it. We talk about pain that spreads a little bit, that your shoulder pain is now shoulder and elbow pain. How does that work? Well, we talk about nosy neighbors. That's your nervous system is just snooping around. What's going on next door to my neighbor? And now you feel it in both areas. So we just explain to them how pain works biologically and the fact that it's okay. And there's cool things you can do. So we talk about movement. When you're in pain, to move. We talk about understanding and don't freaking out, all those kind of things. So I think that's the easier part. The nice thing is we've published quite widely on this stuff. This is not a self-promotion, but there's an article we wrote called The Clinical Application of Pain Neuroscience Education, how to do it in a clinic, step 1, step 2, step 3, that actually has graphics in it that is published. It's public domain. People can find it, and they can. That would be a great start. There are more of those kind of clinical application stuffs coming out, which is awesome.
Yeah, that's definitely good to hear, Adrian. It's encouraging for sure. And let's say that there's a clinician who's interested in working with school-age children and pain education at the same time. What is some of the best ways for a clinician to approach school and faculty admin as far as, effective ways to negotiate the ability to teach pain education in schools?
Yeah, Scott, that's a great question. We went through hell and back to get IRB and approval from parents. What we found is some schools are very easy accessible. Most of your private schools are easier because it's a private school and they just have a board that is approved. Sometimes the principal approves it, for that matter. Public health is a little bit harder. Some schools, it sounds really weird for people in this, but some schools actually require parents to sign off. Other schools did not. It's just every school is different. Just for being thorough here, we went to the Department of Education in Washington D.C. by the way, and they love this, but they do not want to mandate this top down. Every school, every state, every district has its own rules, regulations. So my advice would be, first of all, contact the teachers. The one consistent thing we find is teachers want this. They love it. They love outside speakers. They want help. They're open to this stuff. So most of what we did is we found therapists that have ins with teachers, that knew teachers. And so they contacted the teacher. The teacher went, oh yeah, this is awesome. And then they would use the teacher as the avenue to the principal. And then the principal would either sign off or it would go to the superintendent or the board, etc. So those are the kinds of things we did. Now, we obviously have external IRBs and stuff that we have to do, but I think it's easier. I made a phone call to one of our middle schools just real quick to ask one of the teachers that was my son's teacher a question about something, and he's like, "You're going to come back and do this at our school, right?" And they're super excited for this. So yeah, I'm hoping we can provide a product that's going to be free, that therapists can literally just download and go. Now, what I would like to do is create research that you can go to a teacher and a school and a superintendent and say, there's the research. We're going to make nice graphics with it. We'd love to come help you. And what I like, and I apologize if there's other healthcare providers listening. I'm a big fan of everybody, but I also like the idea that the physical therapists can then use this as I'm going to call marketing, but we have a very bad, I don't want to say bad name in the community, but nobody knows what we do. I mean, what does your wife think you do? Well, you walk old people, you stretch people, right? People have no idea what we really do. So it's a great opportunity for us to do something neat for a generation that also drives healthcare and therapy, non-medicalized.
So, safe, kind of going off of that, Adrian, say that again, there's a clinician that wants to get involved and do pain science education in the school setting. Aside from what you've kind of already mentioned, what are some of the other barriers that potentially limit clinicians from being able to actually get into schools and do something like this?
Well, obviously there's the school stuff, as we mentioned, right? You got to get past the principal, you got to get past the hall monitor, you got to get past the lunch lady and everybody to get into school. I know this is probably not what you're asking, Brendan, but I think you got to get past yourself. We talk about the iceberg effect. When a patient walks in a clinic, and I'm going to spend 30 minutes explaining to you or Scott or Stephanie how pain works, it's an iceberg. I'm showing you a little piece of a lot, right? And so you need to know your stuff. That's as simple as it. So unfortunately, yeah, if you want to go into school and teach about pain, you need to know pain. So a clinician would need to know the material well enough, and there's a lot of resources that you can go out there, those kind of things. You also need to obviously be okay speaking to people, right? It's one of those speaking things you need to be able to do. So it's your knowledge, your ability to speak. I think obviously the classic things, you have to have the passion and the will. And I mean, if I worked for a private practice and the owner said, go to the middle school and teach this class, I would freak out, because it was not something in my wheelhouse 20 years ago. So I'm not answering your question, but those are things that are important, right? So the group that's doing this research for us, these are therapists that they foam at the mouth doing this stuff. They want to do it. They're passionate. They know the material. They happen to have ins at schools already, which is cool. So those are the most common things, yeah.
Have there been any discussions on doing pain neuroscience education to high school students in order to compare findings at all, Adrian?
Yes, we are busy with that. So I don't want to sound like we've done everything, right? But we are, yeah. We sat down, we scribbled out these studies, and then we said, okay, what about high school kids? What about kids that are Spanish speaking? What about below 5th grade? There's some cool things we're doing right now with the team in Belgium with Joe Nice, where they actually designed a board game for little kids on pain. where little kids underneath, fifth grade, below fifth grade actually can do it. So we are looking at various avenues. High schoolers, yeah, they scare me. They're going to have different layers, and it'll be very intriguing because I think, coming back to what Brandon and Scott asked earlier on, they have other layers that we're going to have to deal with. So, but we are actually trialing some of this already. We just don't have any of those results yet.
So, I know you said that you don't really have any results yet, but what is your hypothesis? There's lots of layers, you said. There's more baggage that comes with high school kids versus middle school or elementary school. So what are you guys predicting is going to happen with this?
Yeah, I mean, these are simple studies. So there's pre-post studies of knowledge, right? I think the knowledge will go up. We have now shown knowledge will always go up, no matter what you teach. We can teach you to patients, whatever. I think some of the attitudes and beliefs will change. I think they'll be harder changing their attitudes and their beliefs because I think they're entrenched in some of their beliefs. Being the dad of two teenagers, they have definitely different beliefs. And so I think it's going to be a little trickier to, that's where the behavior thing I think is going to be very intriguing. Will they really change the behavior? I get a son who, if I can get him to cut the grass, I have a great day. And it's very hard to get. Yeah, I think it's going to be more tricky, but it's going to be on the behavior side, Stephanie. Knowledge will go up. When you learn new things, your knowledge goes up. It's almost that simple. We almost shouldn't publish that stuff anymore. It's that basic. But I don't think their behaviors will shift as easy. Yeah.
Do you think that there's like a threshold in kids where it all of a sudden becomes harder to, either they become more at risk for chronic pain or it becomes harder to teach them?
Yeah, probably. I don't know what it is. Obviously, coming back to the way we started today, as you just grow up, there's just more things going on. And, unfortunately, there are things like in high school kids, there's higher rates of divorced parents. There are substance abuse. There are lots of other things that layer that becomes seriously complicated. We know that 50% of school kids struggle with pain. I mean, if you look at the current data, 1 in 4 Americans struggle with chronic pain, and chronic pain is 1 in 3 in kids. So there's serious issues going on, and it seems to be higher in our older kids, for that matter. But there's more. The layers just become more complicated and more deeper and deeper and deeper. So that's why we're saying if we can catch them even before this stuff happens. And I'm purely speculating here, obviously, Stephanie. We don't know yet, but that's what I think that will happen based on the current studies we've got.
That's kind of an interesting perspective because, here in the United States, we're trying to go more toward a preventative model of pain and trying to prevent chronic pain from happening. So, I mean, it sounds like potentially if you can really hit these kids at an early age, I know you haven't specifically studied this yet, but hit these kids at an early age, potentially you can prevent these chronic pain problems from happening in the future. Would you say that that's right?
That would be the holy grail, right? Wouldn't it? But there's so many forces against it. I'm sure Pfizer won't sponsor our research. I'm sure the American Academy of Orthopedic Surgery wouldn't give us a couple of dollars for research. So, yeah, there's a lot of forces against us, no doubt about it. But I'm an optimist. I'm like Tim Flynn, I think we can do it. I absolutely believe it. And we're now beginning to do studies like this. Preventative stuff. We're hoping that these early trials will get enough attention where we can get funding to do what we're doing, but that's okay. I see myself doing this for a long time, and I've got an amazing team around me that's younger than I am. Absolutely, why not? Why don't we can work on prevention? But again, the critical thing people need to understand: we're not preventing pain, we're preventing chronicity and disability. And we can have a long podcast about all the ideas about preventative care, but I think this is something worth studying. It's getting a lot of attention, by the way. It's the way somebody described it recently on another podcast was the idea that we almost inoculate kids against disability. We inoculate them against chronicity, but it'll take society. Because the kids will hear it from us, but they're going to have to hear it on TV. They're going to have to see it in social media. These things will have to happen on a larger scale than we've ever seen before. And sometimes I'm not that convinced the powers that be want that to happen, but I'm just a cynical PT.
Well, and I think, honestly, I mean, not to open Pandora's box here, but, thinking of an analogy, coming back to DPT education, for example, like students can learn awesome evidence-based treatment and assessment of patients in school, but perhaps when those students go out into their clinicals and they're working in environments where that type of practice is not done, and then it can at times negate the student's implementation of that best evidence in these settings, and then they can pick up bad habits. And of course, analogy can also be applied to kids for that matter, especially with learning about pain. But if society and other influences go against that, that's a problem. So I know this is going to open up the box here hugely. I know this can be a huge discussion. I'm not trying to open up a huge box here, but so about taking it to the next level of teaching society so that ultimately more parents and people are on the same page when it comes to an understanding of pain, as we've got to get this understanding on a societal level. And just kind of how do you think is overall the best way to do that?
Yeah, that's a great question. I don't know. I mean, we are doing community-based studies right now. We just submitted for a grant for one of those. We're going to have to go large scale. For us to go as PTs to little towns or cities, we've done a study like that before, by the way, where we've trained the community. Those are okay, but you have to do it on mass media. I go back to this study by Rochelle Bachbinder in Australia, where they had an ad campaign on TV about back pain. It changed behavior massively, but Brandon, the cost was $10 million. We don't have that kind of funding in PT, not even close. Now, people like Tim Flynn will tell you with the opioid epidemic, we do think it's going to come to a point where these companies will have to one day pay billions, if not trillions, into a trust fund for that people like us can go and ask for $1 million, $2 million to run these kinds of campaigns. So we see the silver lining. The sad news is there's an opioid epidemic, but it will have to happen on a monster scale. It needs to be mandated from the top down in some way, shape, or form. There's got to be grassroots, which I think this is the kind of stuff we're doing now. Social media may supersede anything we're doing on TV, for that matter. I mean, you guys are the young generation. I'm the old guy, right? And so guess what? If you start campaigns on social media, it can supersede. You can see it, and this is not a political, but even in this last election, there's things that happen on social media was almost more powerful than what happened on TV. And so we need guys like you and Scott and Stephanie, the young people. This is the stuff that needs to boil from the bottom up, a pain evolution, a pain revolution. And then us old people need to sit at night and watch TV, the evening news, and watch a commercial coming up. And do you have pain? Well, go see your physical therapist. Those, don't take drugs, those kind of things. So it'll take a lot of work. And it'll have to happen on many levels. But this isn't a bad start to just start playing with this idea.
I think the work that you guys, EIM, and so many others are working on as well to kind of make different avenues of this a reality and progress it forward are definitely a big step in the right direction. So I really do admire that, and I think we'll continue to see more of that. And to kind of switch gears a little bit away from kids specifically, in terms of kind of just overall treatment of the person with persistent pain, what have been your biggest lessons that you've learned most recently about managing the individual with persistent pain?
Yeah, that's a great question. I think the biggest lesson I've learned in the last 20 years of doing this is all you can do is you can plant the seeds, water it with compassion and empathy, and step back. The old days, we used to hit it into people. We sit them down, we just hammer it into them. If they wouldn't listen, that's not it. You cannot change behavior that way. All you can do is plant little seeds. No disrespect, but I think of it as evangelism. You can just plant the seeds and see what happens. But we treat people with respect and dignity. We give them everything we got, and then see what happens. Some people will flower right in front of you, go, "Oh my God, Brandon, you're the most amazing therapist I've ever met." Then there's a patient that at visit 5, they come in and say, "Oh my gosh, you're the best guy I've ever met." Then there's a patient that walks out of your clinic, flips you off, tells you something about your mother and your ancestry, and then goes to the other therapist down the street that tells them the same thing, and they go, "Oh my goodness, you're the best therapist." It's not about us. And so I think that's one of the biggest lessons I've learned is it's not about me, because I find a lot of clinicians are burned out, they're tired, they hate this job, and I hate putting it that way, but I meet a lot of them at my courses, and I always tell them it's because you cannot work harder than your patient. I can only meet you halfway, actually 49%. So give them what you got and let them do the rest. And that's behavior change is up to them, not you, right? And so that's probably the best thing I've learned in the last several years about pain science education.
Yeah, that's a really good point, Adrian. I think when it comes to physical therapists, especially, a lot of it seems to be ego and just thinking that we can fix everything and change everything. And sometimes you need to just step back and do the right things. And like you said, plant the seeds. But then there is a sense of responsibility from the patient too. They've got to take it on themselves to want to get better and to do the right thing. So it's a tough lesson to learn, but I think it's also a necessity at this point if we're going to do good things and see good results. So you have this recent study that's been published. You've got one on your desk there, and it sounds like you've got a couple in the pipeline. But what are you focusing a lot of your time and research on currently, and what's in the future for you guys? What are you looking at next?
Yeah, so Scott, I think we have a good understanding now that if we take people with chronic pain, we teach them about pain, there's huge shifts. That part is kind of like a checkbox. We've checked that box. We're still working on that side. The area we've looked at is kind of what we're talking about today, is that's preemptive. So we just wrapped up a study where we took people with acute low back pain and we taught them pain science, which is kind of, if you stop for a second, think about it, like, wait a minute, we taught people in acute pain about pain science, which is kind of, we always thought of pain science education as a treatment for chronic pain. So, and we had great results, by the way, huge shift there. So we're doing a lot of preemptive. We're getting ready. It's just accepted for publication, where we did this stuff in a pre-op knee replacement program, 122 patients. We did it for pre-op surgery, for back surgery, hip replacement. So the preemptive is a big part. That's one. The future is telehealth. And so we just launched 2 weeks ago a virtual reality program for pain neuroscience education, where you actually, in a VR environment, you walk in and you meet your therapist and you go through pain science. Now, I know the clinicians are now going to label us as heretics and we're selling out, but there's 116 million people needing help. And the future of healthcare is to help people help themselves. We're running out of money. And the profession and the people that can figure this out to help our patients is going to be it. So telehealth is going to be a big part of what we're doing. So what we rolled out was a model where a patient will still come and see your therapist. We're not negating that. So go see Scott. He evaluates you. This is what's going on. Listen, I'm here for you. But then your second visit, you actually do in VR in your own home. Then you come back again to see Scott. And you cover things, talk about things, show some exercise. Then they go home and do more VR. So that's the model. As we're aiming down the road for things like bundled payments and stuff like that, which will be coming because we cannot sustain the model we have, it's going to become extremely advantageous. We're working with the VA and the Department of Defense right now, and there is a significant interest in saving money but providing high quality. And VR, no matter how you look at it, and you guys are in education, the future PT school students will be sitting at their house in their underwear with a VR headset, with a cup of Starbucks, and they're going to be in a real virtual classroom in Boston. And there's no way of getting away from it. Surgeons are doing it. We're doing it with patients now. And that's part of the telehealth, which I think we're going to be doing.
Yeah, I totally agree, Adrian, that telehealth is the future, especially as technology advances in medicine. This conversation has been so enlightening, and I feel like it's gone by so fast. I just always love listening to you speak. I've been to many of your lectures. And so I'm really interested in your answer on this question. And this is one that we ask all of our guests. If you could change one aspect of healthcare education in physical therapy or any other healthcare profession, which aspect would you change and how would you change it?
Is it okay if I give you two, Stephanie? Sorry. Number one, I'm gonna be biased to pain, right? And I'm gonna have to say we need to teach the next generation how to deal with pain, or it's gonna eat them alive. No doubt about it. We know that the House of Delegates just adopted the IASP guidelines for pain. It should become front and center in every school. So that's a little piece. In the bigger scheme, and I know my colleague John Childs will echo this quite a bit. We've got to make it cheaper. This whole I don't like these higher education systems where students have to pay through the nose expensive. PT has gone to DPT, which is an awesome thing. It's opened up so many doors, but the money thing keeps becoming an issue. I meet many young kids that come out of school. They're gung-ho, but they're so burdened with the debt, the payments, and they cannot enjoy this thing they signed up for. That's, I think, is a critical part. And it's happening again. The higher systems, although this whole blended model was a fight, and it's still a fight, and people hate John Childs and all these things, it's coming. There is just no way around it. Tertiary education will be the next housing bubble, no doubt about it. And it's beginning to get there. So I think if we can get our kids to come in, learn from us, become great therapists, and they're not overly burdened, I think they're a step ahead. That's what I would say today. And hopefully, if they're a step ahead, they know a little bit more about pain than I did when I walked out of school.
I think that's a really powerful message, because I think that response in terms of the finances and the cost of education has been by far the number one answer that we've gotten from all of our guests, followed by number two being kind of more of an updated curriculum on pain and other avenues that, of course, need to be addressed. And then probably the third one's probably more interdisciplinary opportunities with education. So I think we've got a lot of interesting answers for sure.
Yeah, Adriaan, I can't thank you enough for your time and for coming on the show today. You've definitely been a hero of mine for a long time. I've got a copy of Why Do I Hurt on my desk, and I lend it out to patients all the time. Actually, I've probably gone through 2 or 3 copies at this point just from not getting them back after a while. But, I just actually finished a children's book on pain, and it was basically trying to educate young children through a rhyme. It was just, and I sent it off to the illustrator, so that should be back soon. I'd love to send you a copy when I get them finally. But, it's been a great pleasure speaking with you today, and I'd love for you to tell our audience where they can find you online, on social media and stuff, if they have any follow-up questions or anything they'd love to ask you.
Yeah. First of all, also on the book, we need more of that kind of stuff. So I wish you well with that. Easiest place, International Spine and Pain Institute. ISPinstitute.com is our website, obviously. Unfortunately, I'm an old guy, so I don't have Twitter handles, and I'm not one of the things I tend to hide in a cave. So our social media team hates me because I'm very quiet. But we have, if you go to the Evidence in Motion website, which is our parent company, there's a lot of activity on, dare I say, Facebook, because that just tells you, again, I'm very old. But we have Facebook, obviously, our websites are there. I think nowadays it's as easy as Googling me or EIM or ISPI. We're pretty much everywhere. That's easiest way is come meet me at CSM and say hi, and we can have a beverage.
Awesome. Thanks so much for your time, Adriaan.
You're welcome.
Hey, everybody. Thank you for listening to the Healthcare Education Transformation Podcast, as we greatly appreciate your support to help us advance healthcare education. We are very happy to announce that we have created a new tool to help develop clinicians into better experts. With that being said, we have created the HET Light tool, which LIGHT stands for Learning Integrated Towards Expertise. And what we've done is we've taken our first year's worth of episodes with experts in the fields of healthcare and education, and we've taken one golden nugget or theory on expertise and presented it to you in a very easily consumable format, so that people can take one lesson or nugget per week and map out and plan how to incorporate it into your clinical and educational practices. And by the end of the year, we think you'll be pleasantly surprised at how far you've progressed towards becoming an expert. To find out more, please check it out at pteducator.com/HET, which is also available in our show notes. Thank you again all for your continued support. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.